this PowerPoint through Blackboard. Okay. Now, before I want to start from something very basic, because the purpose of this course is to give you a good understanding of the basic things. Actually, I don't want you to memorize everything, but as you are completing the basic neuroscience course, you should have a very clear understanding. Now, if we start with the classification of nervous system, we classify nervous system in two different ways. One is based on their structure, or you can call in anatomic way. Anatomically, we divide the nervous system into two segments. We call central nervous system, which includes brain and spinal cord, and peripheral nervous system, which includes spinal nerves and cranial nerves. Okay, so if you think in a way that these brain and spinal cord, they are the centers, and then for the centers need to get information from the periphery, right? So when the center receive information from periphery, that is called the sensory nervous system. And then when it send information to control the body parts, that is the motor thing. So that is more like physiological way of describing. But in anatomy, we describe based on structure. So when we divide them, we say peripheral nervous system includes 12 pair of cranial nerves and 31 pairs of spinal nerves. So these are the nerves that bring information. They do both sensory and motor function. So they are not divided according to their function. They are divided according to their structure. That's why we say spinal nerve and cranial nerve. Now, each spinal nerve will have its sensory, component, will have its motor component. And for the cranial nerves, some of the cranial nerves are purely sensory, some of them are purely motor, some of them are mixed. They perform both motor and sensory functions. Okay. Now, if we go to functional classification, functionally we divide the the nervous system into two parts. One is we call somatic nervous system. Okay. Now, in somatic, when we say somatic, is the nervous system that control the parts of our body. Those are under our voluntary control. So which structure is under our voluntary control? It is the skeletal muscle, right? Skeletal muscle. The skeletal muscle will be the part of somatic nervous system. And again, it will have two components. One will bring information from the periphery to the center, right? And the other one will carry information from the center to the periphery. So the one that is bringing information back to the central nervous system, that part we say sensory. And the part that bring orders, central nervous system orders, carry those orders to the periphery, they are called the motor system. Okay. Similarly, if we say somatic part, which is under our voluntary control, then there are organs of our body or parts of our body which are not under our voluntary control. For an example, if we want to control our skeletal muscle, it's under our voluntary control, right? If I want to move my hand, I can. If I don't want to move my hand, I don't move my hand. That's under my voluntary control. So that is the somatic nervous system. But there are organs, like for an example, if we talk about muscles, right? Skeletal muscle is the muscle that we can control. That is under our voluntary control. That's why it is a part of somatic nervous system. But think of cardiac muscle. We cannot control our heart rates, right? Our heart beats at its own pace. We just cannot ask the heart to slow down or speed up. That is not under our voluntary control. So those involuntary organs, those controls which are not under our voluntary control, they are grouped in another nervous system we call visceral nervous system. Somatic and visceral. Now again, in visceral, you need to have sensation carried to the central nervous system, which is sensory, and you need to the transmit the command of the central nervous system towards the peripheral organs. So that is the motor part. Now, the motor component of the involuntary system or visceral system is called the autonomic nervous system. That is our focus for today, right? Autonomic. So autonomic is only if you divide them into four parts, right? Somatic, sensory motor, visceral, sensory motor. Only the visceral motor or involuntary motor is considered to be autonomic nervous system. Now, the visceral sensory we don't call it autonomic, we call it visceral sensory. That is not somatic, of course, because the viscera, we don't have any control on them. So sensation that come back from our heart or from the stomach or from our glands, that are visceral sensory, but we don't consider visceral sensory as a part of autonomic. That's why when we say autonomic, which part of nervous system are we talking about? We are talking about the nervous system that control the structures of our body, which are not under our voluntary control. And we are talking only about the motor component of that, not the sensory one. Sensory, again, we will call it some visceral sensory. Okay. Now let's go. Let's see the difference. Even though somatic is not something that we are interested today, but let me see. This one is hiding some. Okay. There is one actually where we can have a speaker view, and I cannot do that. I don't know. Let me see. It's not working right. Mhm. Okay, better not mess with it at this point. Uh, Okay, so if you look at the somatic nervous system, right? Now, somatic, look at this one. This is the CNS, right? CNS means most of them, these are spinal cord, because CNS is composed of brain and spinal cord. Now, look at the single nerve or single nerve fiber that is coming from the CNS. It is going all the way to the effector organs, the organ that it will control. So in case of somatic, what is the effector organ? It's a skeletal muscle, right? Now, but in case of autonomic, you look at this neuron that is arising from the from the central nervous system, either brain or spinal cord, but it's not the same nerve. In case of this one, the same nerve went to the effector organ, which is skeletal muscle. But in this case, before it reaches the effector organ, in this case, effector organ will be smooth muscle, cardiac muscle, and glands, right? Now look at this one. This neuron is not reaching the effector organ directly. Rather, it ends actually at a ganglia. So, and then at the ganglia, it synapses with the postsynaptic neuron, and that postsynaptic neuron eventually go to the effector organ and control the function of the effector organ, right? Now, let me make clear about two things. Ganglia is where you find the neuronal cell bodies, okay? Now, when we talk about nervous system, especially the central nervous system, we use another term called nucleus. You see, when we talk about the neuron from where the cranial nerves arise, we call them nucleus, because when it is in the collection of cell body within the central nervous system is called the CNS, is called the nucleus. And same thing, structurally the same thing, components, the collection of neuronal cell bodies outside the CNS is called ganglia. Now, this is outside the central nervous system. This is inside the central nervous system. So the collection of cell body outside the central nervous system is called ganglia. When the same thing happen inside the central nervous system, we call them nucleus. Okay. Now, two basic difference. One is the same neuron is going, nerve fiber is going all the way to the effector organ. In this case, they have a stop actually somewhere. They have a station where one neuron ends and another neuron begins, which means there is a synapse there. Okay. Now, again, between parasympathetic and sympathetic, look at this one is parasympathetic, which can be, this is a drawn cartoon. So, and in case of parasympathetic, this junction, this synapse happens within the gland itself. In most of the cases, there are exceptions. In most of the cases, this synapse that took place within the organ itself. Okay, but in case of sympathetic, autonomic again is divided into two components, parasympathetic component and sympathetic component, or parasympathetic division and sympathetic division. Look at this one. In this case, the postsynaptic neuron is long. Now, this second neuron, because here is the ganglia, right? This neuron is after the ganglia. We sometimes call it postganglionic neuron. But because, and also what happened in the ganglia, one neuron ends and another neuron begins. This area we call a synapse. So this neuron is after the synapse. So we sometimes call it postsynaptic neuron. So we use these two terms synonymously, interchangeably. Postsynaptic or postganglionic, they mean the same thing. Okay. So again, in case of parasympathetic, presynaptic neuron will be long, postsynaptic one will be short. In case of sympathetic, presynaptic will be short, postsynaptic will be long. This one is not good enough. It should have been here. So presynaptic is short, postsynaptic is long. Now, there is an exception always, everywhere there is an exception. The cells of the adrenal medulla. Adrenal medulla, do you have any idea about adrenal medulla? Adrenal gland is also called suprarenal gland. Suprarenal gland, we call it suprarenal gland based on its position because it lies just on top of the kidney. That's why we call suprarenal. We also call it adrenal because it secretes adrenaline and noradrenaline. These are the British names, the American names are norepinephrine and epinephrine. So adrenaline and epinephrine is exactly the same thing. And norepinephrine and noradrenaline, they are also the same thing. So the cells of the adrenal medulla, they behave as if they are postsynaptic neuron, like this one. So when the presynaptic neuron end on them, make a synapse on them and stimulate them, in response, they secrete neurotransmitter like epinephrine, norepinephrine, dopamine like those, and they goes directly to the blood and bloodstream then carry them to the effector organ. It's a different way, right? Here it is all the way nerve, here halfway nerve, and the rest of it is the neurotransmitter is carried by the bloodstream. Okay, so these are some common difference between somatic and autonomic. Remember, somatic is always the nerve that controls the skeletal muscle, and autonomic nervous system control the smooth muscle, cardiac muscle, and glands. And the autonomic nervous system has two divisions: parasympathetic division and sympathetic division. We'll go into detail of those. Oh, here. Okay. Now, here is some brief summary and some basic information about sympathetic and parasympathetic. You see, sympathetic nervous system we also call fight and flight system, which means you use this nervous system only in case of emergency, fight and flight. You don't always fight and you don't always flight, right? So, which means it is needed only in terms of flight and fight situation, emergency situation. And parasympathetic, we call it rest and digest. So while you are resting, relaxing, that nervous system that is controlling, that nervous system that is in control at that point is the parasympathetic part of the autonomic nervous system. Okay, we call it rest and digest. Now, there are, in terms of function, in most of the cases, you will see they are just opposite. If sympathetic does something, like for an example, the classic example is on heart. If you have sympathetic stimulation, heart rate will go up. If you have parasympathetic stimulation, heart rate will go down. If you have sympathetic stimulation, your eyes will be dilated. If you have parasympathetic stimulation, your pupil will be constricted. Right? It's like that. In terms of function, in most of the cases, they are opposite. There are some variations. I will mention those. Again, there are two divisions, sympathetic and parasympathetic. So what are the similarities between them? Both are involuntary. So remember, both are involuntary and both are motor. None of them will control skeletal muscle or any voluntary structures. Okay, so they are autonomic. Both of them are two neuron system. Do you remember in the last slide I showed somatic is one neuron system, but autonomic is two neuron system, both sympathetic and parasympathetic. Okay, and first cell body of the first order neuron lies in the central nervous system, and second order neuron or cell body of the second order neuron lies in the peripheral nervous system, and they are called ganglia. Those collection of cell bodies, they are called ganglia. Okay, now how they're different, the sympathetic and parasympathetic. Look at the origin of sympathetic here. You see, they arise from T1 to L2 segment of the spinal cord. This is the origin of sympathetic. Okay, all the sympathetic in our body will originate from this part. T1, thoracic 1 segment, to L2, the lumbar 2 segment, right? But look at the parasympathetic. So this is again sympathetic, right? Look at where the parasympathetic coming from. They will either coming from the brainstem, or they come from sacral spinal cord, right? S2, 3, 4, or they will come from the cranium, from the the brainstem. They in the brainstem they will come through four cranial nerves, 3, 7, 9, and 10. This is absolutely important information you have to remember. 3, 7, 9, 10, third, 7th, 9th, and 10th cranial nerve, they will carry parasympathetic. What is the rest of where is the rest of the parasympathetic coming from? They are coming from S2, 3, 4, sacral 2, 3, 4 segments. Okay. Now, do you have any question up to this point? Any question up to this point? You can talk. Any question? No, nothing? Good. Okay. So then let's continue. Now, this one is a small summary again, showing who is doing what. So now, as I said, most of the involuntary organ will have both sympathetic innervation and parasympathetic innervation, right? Most of them. And again, in most of the cases, what sympathetic will you do, parasympathetic will do just opposite. Okay, but that is not always the case. That is the most of the case. That is what you will see. But there are some targets which receive only sympathetic. There is no parasympathetic innervation to those targets. For an example, blood vessels. Blood vessels receive only sympathetic innervation. They don't receive any parasympathetic. At the beginning, we said most of them will get both sympathetic and parasympathetic, and in most of the cases, they will produce different response, opposing response. But the exception is there are some structures which are like blood vessel. Now, if you have a sympathetic stimulation, what will happen? The blood vessel will be constricted. Okay, blood vessel will contract. Now, if you now some sympathetic response will constrict the blood vessels. So now, as a result, what will be the most common consequence that everybody understand? If the blood vessels become narrow, blood pressure will go up, right? If somebody's blood pressure is going down, what type of treatment you will give him or her? You will, of course, inject some sympathetic stimulants, right? So that the blood vessel can constrict and blood pressure can go up, because you don't want blood pressure to go down below a critical level. That's not what we want, right? So now blood vessel, now if you want to do the opposite, if you want to dilate the blood vessel, you cannot stimulate parasympathetic because there is no parasympathetic there. Either you stimulate sympathetic or you inhibit sympathetic. When you inhibit sympathetic, the blood vessel will be dilated. But in the organs where you have both sympathetic and parasympathetic, either you can stimulate sympathetic or you can stimulate parasympathetic, right? But in this case, in case of blood vessel, which is a very important thing, blood vessel receive only sympathetic. That's why stimulating sympathetic will constrict blood vessels and inhibiting sympathetic will dilate the blood vessels. Like sweat gland. So we have sweat gland in our skin, right? That produce sweat. Now, those are stimulated only by sympathetic. They receive only sympathetic innervation. They don't have any parasympathetic innervation. So for the sweating to occur, you have to stimulate sympathetic. So to reduce sympathetic, the sympathetic nervous system need to be inhibited. Okay. Now, the pilomotor muscle, these are the muscles of the hair follicle. Okay, and the hair, there are the hair follicle on the skin. They are contracted by the sympathetic and they receive only sympathetic. Now, dilator muscle of the pupil. Our pupil size is controlled by two muscles. One constrict the pupil, which is controlled by parasympathetic. The one dilated by pupil, which is innervated by sympathetic nervous system. So if you stimulate sympathetic, pupil will be dilated. If you stimulate parasympathetic, pupil will be constricted. Okay. Now, again, there are some parts which receive only parasympathetic. Like as we said, constriction of the pupil is only parasympathetic. Sympathetic cannot cause the constriction of the pupil. Now, ciliary muscle of the eye, which is important for accommodation, right? When they contract, our lens become more convex so that we can see the near object. Those ciliary muscles are innervated only by the parasympathetic, and the sublingual salivary gland that secrete just the watery solution that are controlled by parasympathetic only. Okay, as I mentioned before, the response in most of the organs are opposite to each other. Most of the organs are innervated by both of them, and when they, like for an example, on the heart rate, on the heart SA node, parasympathetic stimulation will decrease the heart rate, sympathetic stimulation will increase the heart rate. See, like bronchial smooth muscle, right? Bronchial smooth muscle. Sympathetic stimulation will cause dilatation. The parasympathetic will cause constriction. So everywhere you go, you will see they will do the opposite response. Now, there are synergistic actually. In some cases, they are not opposing. They're helping each other, synergistic to each other, like the muscles of iris. Muscles of iris, sympathetic does something. You see, the normal pupil size is maintained by the coordination of sympathetic and parasympathetic. So both of them does something, so the pupil remain a normal size. When you withdraw one, pupil will go in one direction, one extreme direction. Like if you stimulate sympathetic, too much sympathetic, pupil will be dilated. If you do too much parasympathetic, pupil will be constricted. Can you tell me which cranial nerve control the parasympathetic of pupil? Any idea? Which cranial nerve will carry parasympathetic that will constrict the pupil? Just guess. Give me a guess. No guess even? You don't want to take a chance? No grading for this one though. You can be courageous and make a guess. No one courageous enough. Can you tell me, not all cranial nerves will work on the eye, right? Can you tell me one or two cranial nerves that work on the eye, on the eyeball? No one want to take a chance? You see, it's oculomotor, right? Oculomotor is the one that controls the movement of the eyeball. And also oculomotor nerve is special. It carries parasympathetic to the ciliary muscles of the eye and also the constrictor muscle of the pupil. Okay. Now, on the male sex organ, the parasympathetic and sympathetic, they are synergistic. They don't do opposing response. The erection is done by parasympathetic stimulation and ejaculation is a function of sympathetic stimulation. So they are synergistic, not opposite to each other, complementary in some organs, like in the salivary glands. If you stimulate parasympathetic, you see parasympathetic will cause the release of watery secretion from your salivary gland. And if you stimulate sympathetic, that will stimulate the secretion of thick and enzyme-rich solution, enzyme-rich secretion. So when you have a saliva, it should contain some enzymes and also some mucus, right? Watery mucus. So you will have both. So sympathetic and parasympathetic are complementary when they work on the salivary gland. They are not opposite, right? One is producing secretion, one is inhibiting secretion. But sympathetic stimulation, you will see sympathetic stimulation always will cause a dry mouth because the watery secretion is a function of parasympathetic. When the sympathetic is stimulated, it produces mainly the enzyme-rich thick secretion. So your oral cavity become dry. Okay. Now look at the say like on the gallbladder. Parasympathetic stimulation will cause contraction of the gallbladder so that bile can be released, right? Now, in case of sympathetic stimulation, gallbladder muscle will be relaxed so that there will be the bile secretion. Because if you think about it, sympathetic, you are in urgent situation, right? At that point, you don't worry about your fat digestion. Your life saving is most important at that point, fight and flight. So at that point, you will not see a juicy burger and then you eat it and then have it digested actually with the bile. So that is not your priority at that point. So those are the things. Like urinary bladder. If you are under heavy stress, you will not be looking for the restrooms actually to go to void your bladder. So that's why when you are in urgent situation, your bladder will be relaxed. So you don't feel the urgency of going to the restroom to void, to empty your bladder. But when the emergency will go away and now you are relaxed, then you will feel the pressure on your urinary bladder so that you can go to restroom and void empty your bladder. So that's how the nature design things in a way that it's appropriate, right? So while you are in a safe situation, in a resting situation, then of course that is the time to go to look for the restroom and find a place to empty your bladder. It's not the emergency situation because you are running for your life. You are not looking for the restroom at that time actually to empty your bladder, right? And also the sphincter of the bladder, that will be relaxed so that the bladder can be emptied. It will be contracted with sympathetic stimulation so the bladder cannot be emptied. So the bladder muscle will relax, sphincter will constrict. Both of them will prevent the emptying of the bladder. But in case while you are under resting condition, the bladder muscle will contract and the sphincter will be relaxed so that the bladder can be emptied. Okay. So anyway, so it's just like opposite. Now, one term that we sometimes use, we say predominant basal tone. So now, under resting condition, which one will mainly control the basal tone? Most of the time, we are not in fight and flight mode, right? Most of the day, we are in rest and digest mode, like you are doing your regular experiment or something. So that is more parasympathetic, right? But if you think that your paperwork for your animal is not right, your protocol is not updated, you know that iCook is having a lab visit, sudden lab visit by iCook. That will make you nervous. That will stimulate the sympathetic, okay? But normally, you are doing your daily job, you are preparing for your experiment, then, so that is mostly parasympathetic. So most of the day, our parasympathetic is mainly under control, right? So that's what we call basal tone. Like, and then for CP is parasympathetic, like iris, our eye is not dilated all the time, which means under normal circumstances, our iris is partially constricted. Like heart, our heart is not beating at a very high speed, not all the time, no. It's beating in a so quiet, we don't even feel it that our heart is beating, right? But when you go to the gym and do some exercise, at that time your heart beat first. But that is not something you do all the day. That is maybe 1 hour a day or half an hour a day, depending on individual's schedule. So like heart. For GI, under normal resting condition, you eat, you relax, your food is digested. Those are all parasympathetic. So basal tone in the GI tract is predominantly parasympathetic. Urinary system. You see, under normal condition, you are drinking, you are enjoying your drinks, you are having food. So whenever necessary, you can go to the restroom, empty your bladder, do whatever you want to. That's why in most of the places, the basal tone, predominant basal tone is parasympathetic. But some organs which are innervated only by sympathetic. So you cannot have basal tone by parasympathetic like blood vessels. Now, whether your blood vessel will remain constricted or dilated, that depend on how much sympathetic stimulation you are having. If you have more sympathetic drive, the blood vessel will be constricted, blood pressure will tend to go up, right? Now, how much sweating you will have will depend on sympathetic. When you are doing exercise, your sympathetic nervous system get excited, you have sweating. But when you are relaxed, in most of the time, if it is not extremely hot, if you have air conditioned room, you don't have any sweating because you are not doing any physical exertion and you sympathetically stimulate the sweat gland to produce sweat. Under normal condition, it's not. Okay. But there is a difference in sweat gland. Is sweat gland, even though they are sympathetic, their neurotransmitter is different. I will talk about neurotransmitter in a while. Okay, so they have a different neurotransmitter. Now, in some places, they have equal sympathetic and parasympathetic. So in this case, like bronchial smooth muscle, you don't have any predominant tone who is predominantly under control. Normally, under normal circumstances, bronchial smooth muscles, they will relax by alpha stimulation. And you see, with the Ventolin that we take, what do I'm not sure if you are familiar with Ventolin. You must be familiar with albuterol, right? Albuterol is something that dilate you. So if you see the people with asthma, they inhale albuterol. So what albuterol does is that it relaxes the bronchial smooth muscle. That is done by alpha stimulation. That is a sympathetic stimulant. So that relax your bronchial smooth muscle so you can breathe easy, right? So the obstruction of the respiratory passage is reduced. So bronchial smooth muscle is the area where you have same. If there is no predominant tone, sympathetic and parasympathetic play equal role. Now, when we say we denervate, okay, or ganglion block, it will be opposite to the predominant tone, right? Like for an example, for on the heart, predominant tone is parasympathetic, right? Which means heart is beating at the rate of about 60 to 80 beats per minute, right? But if you stimulate sympathetic, heart will beat at a rate of 120, 130, 140 like that. But when you block, if you don't want the heart, if you want to speed up the heart, one thing you can do, you can block the parasympathetic on the heart. So if you inhibit the parasympathetic on heart, who will now, in absence of parasympathetic, who will take the predominant, who will take the role of this controlling this one? Sympathetic will do. So then sympathetic will increase the blood of the heart rate, right? The heart will be beating fast. So this is, you don't have to memorize those, but remember for every organ. Now a few things. First thing is that autonomic nervous system is the nervous system that innervate, that supply nerves or innervate the organs which are not under our voluntary control. That is autonomic. And remember, autonomic nervous system doesn't have any sensory part. It is only motor. Okay. And what are the targets of autonomic? They are skeletal, they are smooth muscle, they are cardiac muscle, they are glands. These are the ones. Now, in most of the cases, and then there are two neuron systems. They are not one neuron system like somatic. Now, in most of the cases, the same organ will have both sympathetic and parasympathetic, and stimulation of them will produce opposing response. But there are some organs which receive only sympathetic. There are some organs which receive only parasympathetic. And in some, even though general rule is that they will do opposite to each other, but in some organs, they produce, they work in cooperation to each other. Okay, so they facilitate the function of each other. So that is exception. That is only in few cases. Now, even though they will have both sympathetic and parasympathetic, they will have a predominant tone. We call it predominant basal tone, who is normally under control. Okay, who is normally in control of the situation. In most of the cases, you will see parasympathetic is in charge of things. And then when you remove parasympathetic from the picture, sympathetic will come in. In some places, it is only sympathetic because in those organs, there is no parasympathetic at all. Absolutely important example is blood vessel. Okay. Now, we said the parasympathetic, you are familiar with the term synapse, right? Synapse is where one neuron ends and another neuron begins. Now, how the information from one neuron is transported to the other one, or information from the nerve ending is transmitted to the effector organ, either skeletal muscle or smooth muscle or cardiac muscle, whatever. How they are transmitted? Their transmission processes, it's a chemical process we call synaptic transmission or synaptic transmission, whatever you call it. Now, for the synaptic transmission to take place, it is in most of the cases, yes, there are some electrical synapses like gap junction, but in most of the cases, they are a chemical process we call chemical transmission. Now, for the chemical transmission to occur, you need a chemical substance. Now, those chemical substances that facilitate or inhibit at the synapse are called neurotransmitter. We used the example of inhibitory neurotransmitter. Do you remember? We say GABA, glycine, these are like glycine. This is an inhibitory neurotransmitter. But epinephrine, norepinephrine, acetylcholine, these are all excitatory neurotransmitter, which means when they're released, they stimulate the organ or they stimulate the synapse. So if you have in the synapse, one neuron ends and another neuron begins, if the presynaptic neuron release a inhibitory neurotransmitter, then the signal will not go any further. That's the end of that signal. Okay. But if in the synapse, if the presynaptic neuron release a neurotransmitter which is excitatory, information will travel through further, right? So that is the thing. Now, how do we manipulate those? For an example, like it's a cholinergic system. When we say cholinergic system, our neurotransmitter that we are dealing with is acetylcholine. When we say adrenergic system or noradrenergic system, our neurotransmitter is norepinephrine or noradrenaline. As I said, noradrenaline, norepinephrine, they are exactly the same thing. Okay. Okay. Now, how the nerve ending they produce those neurotransmitter? Like, look at this one. The choline enters the nerve ending, and then it combined with acetyl-CoA plus choline under the influence of choline acetyl transferase. You don't have to memorize them. This is an enzyme that combine these two, and acetylcholine is formed, which is the neurotransmitter, right? Now, what happened to acetylcholine? Acetylcholine is stored inside a synaptic vesicle. Now, when an action potential reaches this nerve terminal, what happens? It causes the influx of calcium. The calcium goes into the nerve terminal, and this calcium, what it does is that it brings the vesicles, the neurotransmitter containing vesicle, into the nerve terminal. And then eventually by exocytosis, that neurotransmitter is released, and the released neurotransmitter then have receptor on the effector organ. Okay, they bind to the receptor and produce a response. That is the whole story, right? That's how it works. Now, okay, now after once the neurotransmitter is released, we want it to do its job, and then either it disappear. We don't want that to continue for a long time, right? We want the action to take place, and after the action, we want neurotransmitter to disappear from that side, right? Now, how it will disappear? In case of acetylcholine, once acetylcholine is done with its job quickly, then there is an enzyme in the synaptic cleft or in the effector organ called acetylcholine esterase. Now, the one that formed the acetylcholine, combining acetyl-CoA and choline, was choline acetyl transferase. This is the opposite one. This is called acetylcholine esterase. So it will do the esterification. What it will do, it will break down the acetylcholine into choline and acetate. So when the acetylcholine is broken down in choline and acetate, it will not do the job of acetylcholine anymore, right? So that's how it is removed from action, so that it doesn't continuously produce action. Okay. Now, this is the normal situation. Now, if we want to block the cholinergic transmission in any organ, we want to produce an anti-cholinergic response. Like any drug that prevent the action of acetylcholine, they are called anti-cholinergic, right? So how can we do that? We can use a medication called hemicholineum. What it will do? It will prevent the choline from going in. If the choline cannot get in, there will be no acetylcholine secretion, right? Because acetylcholine cannot be produced. Or you can have vesamicol, depending on the patient situation, you use different thing. Vesamicol is something that once the acetylcholine is produced, it prevents it from going into the vesicle. So that if it is not inside the vesicle, it cannot be released. That's how you can produce anticholinergic response. Or you can have botulinum, but what botulinum will do, it will prevent the release of acetylcholine from the vesicle into the synaptic cleft. So that's how you can block the cholinergic response as well. Okay, but If you want to prolong the response of acetylcholine in the place, you don't want acetylcholine to be broken down quickly. Normally they are broken down quickly, but if you don't want them to break down quickly and work for a long time, then what you can do, you can block this enzyme. So if you block acetylcholine esterase, you block this enzyme, so acetylcholine will not be broken down into choline and acetate, so it will keep producing its response. So you can do either way. You can facilitate the cholinergic function, or you can inhibit cholinergic function. So most of the cases, this is the way we block. Either we block in this stage, or we block in this stage. We can block in this stage as well. These are the common ways by blocking cholinergic transmission. And to enhance the cholinergic transmission, you can block this enzyme. You can use a medication that is anti-acetylcholinesterase, so that will block the acetylcholinesterase, and your acetylcholine will be working more prolonged fashion, right? Now, in case of noradrenergic, so what happens is that, tyrosine enters the nerve ending. Tyrosine is the amino acid that is the main precursor. Tyrosine will be converted to dopa, okay, by tyrosine hydroxylase. Will be dopa. From dopa will be dopamine. From dopamine will be norepinephrine. So that is the final product. Tyrosine, dopa, dopamine, norepinephrine. So this is the final product. And then norepinephrine is released in the synaptic terminal, and then it combines with the receptor again, and it produces its response, right? Now again, same as cholinergic, if you want to stop the function of cholinergic system, the noradrenergic system, you can do metyrosine. So if you do that, conversion of tyrosine to dopa will be blocked. So if you block here dopa, there will be no epinephrine, right? Or you can use reserpine that block the dopamine from getting into the synaptic vesicle. That is another way you can block it. Or you can use guanethidine that block the release of neurotransmitter into the synaptic cleft. That's how you can produce noradrenergic response. Like now, in this case, in case of acetylcholine, the common way for the acetylcholine to disappear from the site of action is by the enzyme. The enzyme break them down. But in case of norepinephrine, it's different. They are taken back inside the synaptic cleft, inside the synaptic terminal. So you see, as long as they are here, they will keep producing their function, right? So now some of them will be taken back, so their response will stop, and some of them will diffuse away or will be metabolized in that area. Okay, there are different ways of metabolizing. So which means this is the first of all, you need to know the normal situation, what normally does, and there are several ways we can either prolong the function of this neurotransmitter, or we can decrease the function of this neurotransmitter. That's how we call ganglion blocking agent, because you block at the ganglia, so that when you block the ganglia, there is no further response. Or if you can enhance the action of the neurotransmitter by, say, like if you use cocaine, okay, cocaine, that will inhibit the reuptake of norepinephrine, which means norepinephrine will be in the system for a longer time, so you will feel excited. Okay, now if you want acetylcholine to work longer, you block this enzyme, so that acetylcholine will keep working for a long time. Okay. Now, this one, I don't want to get into too detail of this one, so if you see how, so this is a somatic nervous system, right? How a spinal nerve is formed. Now, where is this one coming from, the autonomic? If I bring it here. Okay. So now look at how this, so this is the source of autonomic here. Okay, these are called the normally in other segments of the spinal cord, except for the thoracic 1 to lumbar 2, you will see a lateral horn. We say dorsal horn, the ventral horn. In case of T1 to L2, there is a lateral horn as well. What lateral horn is doing? Lateral horn is the source of sympathetic, right? Look at how sympathetic is coming. You don't have to worry about this. I'm just quickly showing it. So you see they will, oh, why they are not moving? Hmm. What happened? See, now this is the source, right? You see the red dot here? This is the source of sympathetic. Now look at, see, sympathetic fiber is coming, it's following the somatic nerve, the ventral horn of the somatic nerve. And then, but they cannot go directly, right? Because we said there are two neuron systems. They have to go somewhere and synapse so that they can be active. So they leave the nerve and then they come to this ganglia, right? And then in the ganglia they synapse and then they join back the somatic nerve, and they are, and these two parts we call gray, white communicating rami, gray communicating rami, right? They are communicating this nerve with the ganglia. So this is the ganglia where the synapse and postsynaptic neuron goes back to join the somatic nerve, right? Spinal nerve. Now, one thing you see, this is between T1 and L2, right? That is where you have the lateral horn. So you see the autonomic nerve is coming, the sympathetic nerve is coming, going following the ventral horn, and then at some point it leave it, synapse, and go back and join it, and then is redistributed. Dotted lines are postsynaptic fiber or postganglionic fiber. They are distributed. That's simple, straightforward. But you don't have any, see this cervical segment, there is no lateral horn, so there is no source is only between T1 and L2. For those areas, the source, the fibers will come out from the source and they will go up and supply those areas. Okay, now below L3 to coccygeal 1, they don't again have any lateral horn, so they will arise from the T1 to L2 and they will come down and to supply those areas. Okay, now source of sympathetic again is important. Source of sympathetic is only limited to a only T1 to L2 segment of the spinal cord. Above the level of T1, some fibers arising between T1 to L2 need to go up and supply those areas. And the areas below L2, there is no source of sympathetic. So the fibers should come out from T1 to L2 and go down and cover those areas. So some of the fibers will go up, some of the fibers will go down. From T1 to L2, they can go on the same segment. So that's why there will be no white rami about the T1 or L2, because you don't have two communicating rami, because you have one is already inside your sympathetic chain. You need one communicating rami. You don't have to worry much about this one. This maybe could be difficult for you. Now, sympathetic, sympathetic goes to the body wall. We showed how sympathetic goes to the body wall, but sympathetic need to go to the viscera as well, right? Because the viscera, like stomach, esophagus, duodenum, all these organs, they need sympathetic supply as well, right? So we talk about how they go to the body wall. Now look at how they are coming to the viscera. You see, so these are going to the body wall, okay, on the lateral direction. Some fibers are coming this way, and then see they form a nerve plexus on the esophagus, and they form a nerve plexus around the heart and lung, and they provide sympathetic innervation, right? So because those organs need sympathetic innervation as well, and they are called the splanchnic nerve. Now, okay, so one thing I mentioned before is that sympathetic ganglia are located in the sympathetic chain. But in addition to sympathetic chain ganglia, there are some other ganglia of the sympathetic, which lies, this is the aorta, right? Descending aorta. There are some ganglia which are located anterior to the ganglia, anterior to the aorta. They are called pre-aortic ganglia. These are sympathetic ganglia as well, where sympathetic, presynaptic sympathetic fibers can come, synapse, and postsynaptic fibers arise from there. Now, depending on I'm not sure if you are familiar with the branches. Three main branches that supply the organs of the abdomen and pelvis. They are called, these three of them: celiac trunk, superior mesenteric, and inferior mesenteric. Three arteries, and their ganglia are named according to the arteries. The ganglia close to the celiac trunk, which is an artery, is called celiac trunk, and the supramesenteric is the one here, which is related to the supramesenteric artery, and this one is inframesenteric artery, and this one is the inframesenteric ganglia. Okay, the ganglia are named according, they run with the blood vessels, and that's how they are. So you see, at the beginning I said there is an exception. So this is sympathetic chain ganglia, right? So one thing is sympathetic fibers, where do they originate from? They originate from the lateral horn cells between T1 and L2 segment, right? Now, once they come out, they can synapse here, right? And then postsynaptic fibers goes to the organ. Or you see, look at this. These fibers are crossing these ganglia without any synapsing. And then they can synapse in the pre-aortic ganglia, the ganglia that I showed in the last slide. They can synapse here. Or they decide not to go to the ganglia, or they come to the ganglia, but they leave without synapsing in the ganglia, and they come to the adrenal medulla. And adrenal medulla will secrete norepinephrine, epinephrine, and they travel by the blood vessels, and blood vessel will carry them to all the effector organs. So sympathetic, we said a few things. We said sympathetic and parasympathetic, both of them. They are two neuron systems. So for in case of sympathetic, where the first order neuron begin, they begin in the lateral horn of the spinal cord. Which part of the spinal cord? T1 to L2. Okay, T1 to L2. Now, we said there are two neuron system, which means the first neuron that is arising from here, it need to synapse somewhere, right? So in case of sympathetic, they have three places they can go. One is just on the side of the vertebral column, there is a sympathetic chain. They can come and get synapse here. Or if they go to the viscera, they can come to the pre-aortic ganglia and synapse there. Or they can go to the adrenal medulla and synapse there. These are the three possible places where sympathetic nerves can have synaptic connection with the postsynaptic fibers. Okay, now this is more like a summarizing the sympathetic system. You look at this one. So this is the sympathetic chain. Even though the sympathetic fibers arise from T1 to L2 from this area, but sympathetic chain is extending from the base of the neck all the way to the coccyx here, even though the presynaptic fiber arise from this part. Okay, and then some of the presynaptic fibers, instead of synapsing here, they go, you see, they don't synapse in this ganglia, they go directly through the ganglia and they synapse. This is the aorta, right? In front of aorta, celiac trunk, supramesenteric, inframesenteric, they synapse with those ganglia and they provide nerve supply to the viscera, abdominal viscera. Now look at this one. So origin is from T1 to L2, no other origin, but sympathetic chain extending from base of the neck all the way to the coccyx. So fibers arise from here, either they synapse here and postsynaptic fiber go to the organ, or they can leave without synapsing and then they go to the heart and then synapse there in a small ganglia, and then postsynaptic fibers go from there. Okay, so look at this one here. So this is the aorta here, you see, and there are ganglia, pre-aortic ganglia. They may come here without synapsing, synapse here, and go innervate the abdominal organs. Okay, that is more like a summary. Now, parasympathetic. Now, we said the origin of sympathetic is thoracolumbar, right? They begin at the thoracic one, they end at the lumbar two. But for parasympathetic, it's not the continuous. They either will come from the brainstem, we call cranial outflow, or they come from the sacral spinal cord, we call sacral outflow. So their origin is in two different places, either in the cranial or in the sacral. That's why parasympathetic is also called craniosacral nervous system. Okay, so how do they come out from the brainstem? They come out through four cranial nerves. What are those cranial nerves? Look at here. There are third, seventh, ninth, and 10th. These are the four cranial nerves that carry parasympathetic. Okay. And then 3, 7, and 9, they will stay within the face, okay, within the face area, or they don't go below the neck. But the 10 will cover below the neck all the way to the colon. You see the large intestine, they supply all the way to the end of transverse colon. Okay, so who will do the rest of the body for the sympathetic? You see, we have another source here that is called sacral outflow. Which part of sacral spinal cord they're coming from? They're coming from sacral 2, 3, 4. Again, in the sacral 2, 3, 4, there will be some lateral horn. From there, preganglionic presynaptic fibers will come. They will come to the viscera and they will do synapse, and short postsynaptic fibers will arise from there. So for the parasympathetic, from the head all the way to the part of the abdomen, it is cranial 3, 7, 9, and 10. And from the descending colon and the rest of the anal canal and the pelvic viscera, they are supplied parasympathetic by sacral 2, 3, 4. Okay, they originate from sacral 2, 3, 4. See, again, they will have long presynaptic fibers and short postsynaptic fibers. See, this is presynaptic coming all the way to the organ. The synapse here, and very short postsynaptic fiber goes to the organ. Okay, only in case of parasympathetic, only these are the four ganglia. They are not within the organ itself. They are a little away from the organ. They are called ciliary ganglia, the pterygopalatine ganglia, otic ganglia, and submandibular ganglia. These are called peripheral parasympathetic ganglia. Other than these, all parasympathetic ganglia, they lies within the organ which they are innervating. Okay. Okay. So the craniosacral, the cranial root will come through 3, 7, 9, and 10, or at the sacral spinal cord, levels are 2, 3, 4. Right. So, and then now parasympathetic, we said cranial outflow will come through 3, 7, 9, and 10. But 3, 7, and 9, they will remain in the face area. They will not supply anything below the face. But it is vagus which will supply the neck, the thorax, and the part of the abdomen. That's why vagus, parasympathetic supply of vagus is so important. Look at this fiber. These are all parasympathetic, is all from vagus. You see, they're doing this esophagus, the trachea, they're doing the esophagus here, trachea here, they're entering the abdomen. This is the diaphragm, entering the abdomen, stomach, and all the way to the second part of the large intestine, the transverse colon. Okay. Now look at the parasympathetic. So this is all this parasympathetic are done by vagus, and the rest of it is done by sacral 2, 3, 4, S2, 3, 4. Now you can see how they are formed. You see, at some point, these are sympathetic nerves actually coming under the diaphragm. But you see, when they form ganglia here, we call plexus is the bundle of nerve fiber. Aortic, when you say aortic plexus, it is not sympathetic, purely sympathetic or purely parasympathetic. They are mixed fiber. They contain sympathetic fibers, they have parasympathetic fibers. But these are sympathetic chain ganglia. See the sympathetic chain ganglia here? And then there's ganglia. These are all sympathetic ganglia. And parasympathetic fibers here are all from the vagus. Okay. And then at some point, some fibers will come from sacral 2, 3, 4. You see, it's here. You see the sacral nerves here, sacral 2, 3, and 4. You see some small fibers are coming here. Here, look at this one. This one is clear. This is sacral 1, sacral 2, sacral 3. These are spinal nerves. Now look, from sacral 2, something else is coming. Sacral 3, something else is coming. Sacral 4, something else is coming. And they join, they are called the pelvic splanchnic nerves. When we say splanchnion is the viscera, right? Splanchnic nerves are the nerves that provide nerve supply to the viscera. Look at this one, the rectum, anal canal, urinary bladder, and the pelvic viscera, male, female, sex organs, they are all innervated. Parasympathetic innervation come from sacral 2, 3, 4. Okay, they are called pelvic splanchnic nerve. Now here, so this is the innervation of the pelvis. See, look at this one. What I wanted you to see is, see sacral 2, 3, 4, sacral 1, sacral 2 here, 2, 3, 4. You see the nerves coming here. They join the other nerves. They form the different plexuses. They form the bundle of nerves here and provide innervation to. You see, these are female organs: uterus, bladder, uterus, and ovary in case of female. In case of male, they provide innervation to the testis, penis, and the prostate. So these are the difference in organ in two different sexes. This is the autonomic innervation. It's to the viscera. This is just like a summary. Look at the origin of sympathetic is not from T5, T1 to T5. Okay. Now look at this one here. They are coming here. So they synapse. They don't synapse in this pre-out. We call them, the prevertebral ganglia, the sympathetic chain ganglia. These fibers, they don't synapse in the presynaptic ganglia. They go into the pre-aortic ganglia. See here, 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 and provide innervation, sympathetic. On this side, showing sympathetic. Now look at the parasympathetic. Either they will come from sacral 2, 3, 4, or they will come from brainstem via 4 cranial nerves, 3, 7, 9, 10. Remember the source, at least. Source of sympathetic is lateral horn of the spinal cord, beginning T1 to L2, and the source of parasympathetic is either cranial through 4 cranial nerves, 3, 7, 9, 10, or sacral to 3 spinal cord segment, lateral horn, which is sacral 2, 3, 4. Okay, I think we talked about a lot of things. See, do you have any question at this point? If you don't have question at this point, you are always welcome to ask question through email or through, you have my cell phone. You can send me text message, call me, whichever way is convenient for you. Any question at this point?
A quick question. This is just about the test. Will we get some kind of will we get the test back with notes about like what we missed points for, anything if we happen to miss points?
On the exam too?
Yes. Yeah.
Oh yeah, sure.
Oh, great.
So if you want to talk about your exam, I can always have a one-on-one Zoom with any one of you. If you have any question, concern, I can definitely talk. And so what you can do, because I cannot talk about the everybody's the answers and the scores in the open forum. But if you have any question that, okay, I got this, but I expected this, so where is the problem, where I lost points, you can always send me email. I can set up, if you want to have a Zoom, I can have a Zoom meeting with you. It can be short at your own convenient time. I am available anytime. It can be during hours, during after hours, whichever is convenient for you. So I can sit and I can share the screen with your answer that you sent me, and I can show you if you lost any point, what was the reason why you lost those points. Okay, is it clear enough?
Yes. Yeah. I guess I was just wondering, like, will we get the test back with like annotations on it, or is it like only if we set up a Zoom meeting?
That is not a routine thing that we do, that return the exams with annotations. But if you want, these are only on request. If you want to see your exam, then it have to be on an individual basis, and it's not something that we send the exam papers with annotation to everybody. That's not the norm. That's not what we do. But as I said, if you want to discuss your exam with me, I will be very happy to do it with you.
Sounds good.
Thank you. So any question from today's thing? Because to cover the whole autonomic in one lecture is a bit problematic. And also if you know the basic anatomy, then it's relatively easier. But if you don't have understanding of anatomy, and most of, because you're from diverse field, so I don't expect you to have that even. So in that case, it's not easy actually. It's little difficult. But as I said, if you have any question, or what do I expect you to know actually from this, because we talk about so many things, it's impossible for you to memorize everything. But again, this exam will be, again, it will be a take-home exam as well. It's an open book take-home exam. So I will give you some, a question from the autonomic, just more like a descriptive question. So you can consult your book, you can check the PowerPoints, and then come up with your answer. The way you did in the last exam was good, actually. So
I have a
question?
question.
Go ahead.
So what about situations that aren't necessarily like cut and dry in terms of like fight and flight or rest and digest?
Mhm.
So would it be more of like the body's under stress and it would fall more under the parasympathetic? Like for example, like situations that occur over a long period of time where like maybe the body isn't getting enough nutrition, or it's really cold out and the body's like trying to draw warmth into the core. Like where would that fall under?
That is, now it depends on which organ is involved here. So see, if you are exposed in a cold temperature, then your primary focus will be to retain heat, right? You don't want to lose heat. So for that to happen, you don't want too much blood to flow, because if the blood flow in your peripheral parts of the body, like in your hand, so for the hand, you see your hand will become extremely cold during the winter time, because you want to preserve your temperature. So that temperature flows in your blood. If the blood end up here, it will lose some temperature actually. So our body don't want that. So body want to conserve the temperature. Now, for that to happen, we said in the blood vessel and the sweat gland of the skin, there is no parasympathetic innervation. It's only innervated by sympathetic. So now what you can do, the sympathetic got stimulated at the time because it's an emergency situation. So the blood vessels are constricted. So very little blood flows into the periphery. That's why you feel the peripheral parts become colder. And that's how we conserve heat. The, the, uh, the, the joint action of sympathetic and parasympathetic is only when the structure, as I said, in most of the cases, they are innervated by both nervous system. So they say, like, for an example, if you want to see something, when the things come close, okay, you need to constrict your pupil, and then you want to contract your ciliary muscles so that your lens become more convex. In that case, it is parasympathetic stimulation. Okay, normally there is a balance between sympathetic and parasympathetic, so your pupil has a certain opening, right? Now, if you want to dilate your pupil, then either you have to block parasympathetic or you have to stimulate the sympathetic. In the organs where you have both sympathetic and parasympathetic, but as I said, in the blood vessels, now someone's blood pressure is going down, so you want to elevate. That happen mostly in case of accidents or some heavy blood loss. So someone's blood pressure is going down. What do you want at that point? There is no sympathetic in picture because blood vessels are all only under control of sympathetic. What you want to do? You want to stimulate the sympathetic. You apply some medicine or medication, which we call sympathomimetic, which means they behave as if they are sympathetic agents. So they will act like a sympathetic and increase the contraction, the smooth. They will cause the contraction of the smooth muscle of the blood vessels. So when the smooth muscle become contracted, blood vessel become narrow. Okay, blood pressure is the product of the cardiac output and total peripheral resistance. Are you familiar with that? Like blood pressure. How do we get blood pressure? It is the cardiac output. How much blood is going out from the heart per minute plus peripheral resistance. How much resistance you are giving? It's a multiplication. Blood pressure is equal to cardiac output into total peripheral resistance. So now, if you increase any of those two, the blood pressure will go up, right? Now, if you apply sympathetic, heart will pump stronger, which means cardiac output will go up, and the blood vessel will be constricted, so the resistance will go up. Peripheral resistance is going up, so that the blood pressure will jack up, right? So if somebody, you just cannot maintain the blood pressure of a patient. It's going down and down at a critical level where the patient may not even survive. So only way for you is to stimulate sympathetic or inject something that is sympathetic, sympathomimetic in nature. But by blocking in other organs, you can block parasympathetic. But in blood vessel, you cannot block parasympathetic because there is no parasympathetic to begin with. Like, any organ where they have opposing response, you can suppress one or you can enhance one. But those which are in a structure which are innervated by only one system, only way you do is to stimulate or enhance stimulate or inhibit that system. Either it is sympathetic or parasympathetic.
Okay, so maybe instead of like a fight or flight response, it's more of like a stress response and looking at the systems involved and how they're innervated.
Mm-hmm. Well, I didn't get it. Can you repeat it?
So instead of just looking at it in terms of a fight or flight response, could it also be considered more of a stress response and looking at the systems involved and how it's innervated?
Oh, yeah. Yes, sure. Because stressful condition, you see, there are some chronic stressful condition. Those are a little different actually. Because if you apply a stress to an animal, like we do it with the animal experiment all the time. If you apply, if you expose an animal to a stressful condition, immediately the first response of the animal will be sympathetic stimulation. So you will see all the response, classic response of sympathetic stimulation in that particular animal. But if you apply that, if you keep that animal in that stressful condition over a long period of time, ultimately some of the thing will got into a stage of adaptation. So you see, initially the amount of sympathetic drive you saw in that animal, you will not eventually see those. But in some organs, they will last little longer. In some organs, that's why sustained stress is very different than a short-term stress. Short-term stress, you will see the classic example of sympathetic stimulation. Now, when you apply it long-term, there will be some adaptation there.
Okay.
Okay, so it will not be that straightforward sympathetic stimulation because some of the organs will adapt more quickly than the other ones in response to stress. You see, if you say normally what we do, we work during the day, we sleep during the night, right? We take rest during the night. Now if you put someone on the night shift, initially it will be stressful. And then, you see the blood pressure is elevated, the person is irritated because of the sympathetic stimulation. But if that become the norm, that individual is working at night all the time, then the system will readjust with it, actually, some of the thing. So not that sudden stress or sudden unusual situation will not last for a long time in some organs, but some organs will respond differently for sure.
Okay, that helps.
So any more question? Any queries? No? Good, then we are good to go. It's about 11:50. Are you joining the seminar today? We have a department seminar actually. I got 10 emails actually to join this. This is coming from Dr. Charles, coming from Sharon, coming from Dr. Meyer. I don't know what, and coming from DDEI. Do you know? Are you familiar with DDEI? The Division of Diversity, Equity, and Inclusion. I got 2-3 emails from them. Diversity, I got from Dr. Meyer, I got from our chairman, I got from the chairman's assistant. It's coming from all over. So I have to join.
Yes, they really want us to go.
And those who are from neurobiology, they have to join for graduate students, of course. So anyway, thank you very much for joining today. And I will remind Dr. Hire about his class and also Dr. Childs about your class next week. Okay. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.